I wear many hats in this arena. So wearing my research hat, there is something I must do because it is my first opportunity to do this, and that is to say an enormous thanks to the psychedelic community, actually, for holding the space, for promoting the science, and dialogue and believing in, I guess, the therapeutic potential of psilocybin until science was allowed back in the landscape. So thank you. Especially for, Entheogenesis Australia, PRISM. I'm going to have lots of love for PRISM later on as well, and also the Australian Psychedelic Society. So thank you so much. You've enormously helped our cause to get this off the ground, so thank you. So now I've given you all a big psychological hug. I've got lots to talk about, so we'll get started. And also a shout out to two young guys that found me wandering aimlessly and redirected me back to the auditorium, so thank you. Otherwise I wouldn't be here. So I guess we don't have results, we haven't started yet, so there's, I thought about what I can talk with you about. And I guess the question that I'm most frequently asked is, what made you want to do this? So we'll talk a little bit about that. So it's going to take a little somber tone for a moment, given the population that I work with. The other question that I get is how we made this happen. How in the hell did you get this across the line? So I'll give you little snippets of the story as it happened. So then it's not entirely cerebral. So if you're looking for an academic lecture, you've come to the wrong talk. But I will touch only very briefly on previous studies. They're a great read, but I'll save you the trouble, give you the spoilers. And then we'll talk about, how we managed to get it where it is now, and a little bit about the trial and what we hope to achieve. So strap yourselves in. Here we go. So why? This is the most common question. A little word about me, not much. Obviously, clinical psychologist, worked in research. I've worked in clinical trials before as a case manager with homeless youth, and then with youth who are at risk of developing psychosis, as a lead clinician working with adults who suffer complex trauma as well. So I'm very excited by the work of the groups with MDMA and PTSD as well. But then moved into the area now where I work with the incredible humans who have been diagnosed with terminal illness. From all stages, from curative cancers, from diagnosis, and then all the way through to end-of-life care. Now, you may think this is depressing. It is actually incredibly privileged work. To sit at someone's bedside when they are at the end of their life is a profound experience. And for much of the time, it looks like this. I'm very happy to say that a good portion of the work that I do and the people that I meet are summed up in this image. The patients are older. They've lived a full life, of course, some regrets, some more than others, but they're tired, they're ready to go. Those aren't my hands, by the way, but I do get the privilege of holding their hand if they reach it out to me. I've held many hands, many dying hands. And those are the good days, and these are the good cases, but that's not who we're doing this for. There are a number of my patients who are diagnosed with terminal illness who do not want to die, and they are terrified. When they're told that their disease is terminal, it is devastating, and life as they know it is completely upended. Any plans that they have are just shelved or cancelled, put on hold. All of a sudden, the future is uncertain and frightening. And what tends to happen is that people's identity is very often infused with their illness, because all of a sudden their life is taken over by medical appointments, procedures, invasive procedures sometimes, quite scary things. And they're dealing with a body that is increasingly unwell and dependent on others. So the uncertainty of their future creates significant anxiety, but also consider this. The treatments that we offer people, and the reason I'm telling you this is because I want you to get a bit of an idea of psychologically what happens for our palliative care patients. Because when we think of palliative care, we think of providing them physical comfort in the end of their life. But they could be completely free of pain and nausea and other symptoms, but they may be anguished and terrified or depressed and despairing and withdrawn. So, psychological care is very deeply embedded in palliative medicine, and that's where we come into this. So I'm just giving you a little overview of why our patients are so desperately needing alternative treatment here. I'm a bit, okay, I'll really bellow. Here we go. All right. But often the treatments that we offer people really leave people feeling quite massacred, disfigured, and that can leave them with many pretty major changes to their body that's quite visible, loss of hair, loss of body parts, like breast or prostate, and that can really affect their sense of gender as well. There's swelling, there's weight changes and so forth, and this has a massive assault on one's sense of identity. And when you think about that, that shakes them to their very core about who they feel they are. So that's no small thing in terms of a psychological event. So from a mental health point of view, there's a hell of a lot going on. So it's no wonder that the rates of anxiety and depression in palliative care are much higher than the general population, much higher. More than a third of palliative populations have experienced a depressive syndrome of some type. I think in one Australian study it was as high as 45%. And then, up to a third of our patients will have anxiety to some degree as well. So we've got really high rates and high prevalence of mental health distress here. The other problem that we know about is that psychological distress is known, and there's a lot of research to show this. If you are distressed, it augments your experience of pain and nausea and all these other symptoms as well. It can contribute to sleep disturbance. So it's not just psychological suffering, it then makes your physical symptoms very difficult to treat. So there's lots of reasons why we need to think about how we can treat this more effectively. So there's lots of fears. They're often very fearful of the dying process and death itself, people they're leaving behind. So with such a high rate of distress, you'd think we'd have a lot more in our arsenal. But unfortunately, we don't. So essentially, if you have psychological distress at the end of life, your treatment options currently fall into two clusters overall. So we've got medications, so things like antidepressants, anti-anxiety medications or other kind of mood stabilisers, which really only mute symptoms, honestly. It can provide some symptomatic relief, but it really doesn't get to the core of what's going on for them. So the problems remain, muted sort of a sense, and it can be enough for some people, but it really does still remain. The other problem using these kind of medications is, like, for example, anti-anxiety medications, so Valium, for example, or lorazepam. You can get really serious dependence on that if you use that quite frequently, and often we need to give people quite high doses of that. So the risk of developing dependence and then tolerating it, so then you need more of it to get the same effect. And then withdrawal or interaction effects. These are really big problems, though, with the current treatments that we have. And we also know that anti-anxiety medications, for example, can also increase people's chances of developing a delirium, which is actually very common in terminal illness. But then on the right, we've got talking therapies, and there's quite a number of those. So we've got meaning-centred psychotherapies, calm therapies, blah, 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 all that sort of thing. Dignity therapy, you name it, we've got heaps. Mindfulness-based therapies as well. And then we've got the creative therapies, which are very important as well. So art therapies and music therapies. Really, really important for people who are unable to speak their pain. They may not have language, and they may not just be used to using their mouth as being able to talk about their problems or their emotions. So, creative therapies really gives them another medium of being able to sort of express that. And again, talking therapies can achieve a depth, I guess, that obviously the medications can't that way. But unfortunately, research overall has really only indicated very modest effects, or momentary effects, unfortunately. And a lot of the randomised controlled trials that investigate the efficacy of these treatments have really been done in curative populations. So people who are, looking like they're going to actually go into remission. So I think, unfortunately, we really haven't made too much of a mark in this regard. We know that meaning-centred psychotherapies tend to be really good for death anxiety, but it's just not cutting it, and it's not good enough. So if people don't respond to these two treatments, there is very little that can be done. We can support them, we can do as much as we can. We don't give up on them, don't worry about that. But as a clinician, when you're working very closely with your patients and you see this sort of level of suffering, it is heartbreaking. It is heartbreaking for the patient, it is heartbreaking for their families. And when people are, and look, luckily enough, this is not a majority, there are a smaller number of people, but for them, they are unable to enjoy the precious remaining time that they have meaningfully and with their loved ones. So this is the problem that I faced as a clinician, and it wasn't just myself, obviously people in my field as well. And then this guy made a serious comeback. So in 2016, there was a huge breakthrough. So Johns Hopkins and NYU had published their seminal findings of treating depression and anxiety in cancer patients, and the results were stunning. So the top one there, so Johns Hopkins, that was the NYU study, 60 to 80% achieved remission of depression and anxiety symptoms, and this was maintained at 6 months follow-up, and this was after 1 dose of active psilocybin. Now, again, this is shrouded obviously in preparatory psychotherapy and then integrative psychotherapy, but this was 1 dose of psilocybin. And then, yeah, even better again for Johns Hopkins. So this was 80% reduction of depression and anxiety symptoms at 6 months. They had 2 sessions of psilocybin, but the low dose was extremely low. Like, I don't even think it would be enough to be a microdose. So it was really, really low. It was trying to act as a placebo. And then quite a high dose, pretty whacking dose actually. So they had phenomenal results. Now, a couple of tidbits about these 2 studies. Just in case you're interested, the most common side effects, because people go, well, it sounds dangerous. Okay, all right, most common side effects. Transient nausea, when the psilocybin began to kind of go into lift-off. Transient headache. Transient low-grade paranoia for maybe, I think, 1 or 2 people, which abated within the 6 hours, and a non-clinical elevation in blood pressure, and that was about it. All of these wore off within the sort of the 6-7 hours dose session, and there was no need to employ what they call rescue medications. Now, rescue medications were there in case anyone needed them. What they entailed were things like benzodiazepines, like Valium, or antipsychotics like olanzapine or so forth, to help people if they were agitated or if they were anxious, or they became quite acutely unwell. So there was no need to use this. In all instances, if people were distressed, they were able to be reassured with a psychological intervention and good preparatory psychotherapy to begin with, to help them learn how to do that. So I think that's important to talk about that as being another huge achievement that was sort of not, it was kind of lost in it all as well. Now, I don't know if there's anyone here from psychology or psychiatry, but the reduction of symptoms in these studies were not only impressive for the area that I work in psycho-oncology and palliative care, but for psychiatry in general. Nothing like this has been produced at all. It was just stellar. So it certainly made me look twice. It looked almost too good to be true. So I reread those articles. It was amazing. So why does psilocybin produce such profound changes in mood and cognition and behaviour? Well, we do know that psilocybin itself is an indole alkaloid. It converts to psilocin when it's ingested, and it works on serotonergic receptors. Sorry if this sounds a bit garbled, but basically it works on the same pathways that serotonin works. So serotonin being your happy kind of mood neurotransmitter that we all have. And it works on the same receptors that your, say for example, if you took an antidepressant, the same receptors would be targeted there. We know from the work at Imperial College London that psilocybin tends to relax the default mode network. I'm not going to try and speak as poetically as Robert Carhart Harris can about this, or even Dean, but I will tell you that from a psychotherapeutic point of view, it does something very, very interesting. It's a network of brain circuitry that's activated when our brains are more at rest, when we're kind of reflective, self-referential, when we're thinking about the past, when we're thinking about the future. Now, this is very interesting because when we're at rest, we also tend to ruminate. And we think of ourselves in the past, we think about what we want in our futures, blah, blah, blah. Now, this sort of ruminating is really rigid and very negativistic in depression and in anxiety. So it makes sense that when the default mode network is relaxed, so is our habitual rumination and the quietening down of one of those mechanisms which we think allows other perspectives. So for a while there, we just stopped that rigid kind of thinking, and other perspectives are possible for us. So from a therapeutic point of view, that's really exciting to me. And also, if we think about psilocybin, particularly for the people who are terminally ill, its ability to occasion very intense mystical or spiritual experiences. For the person who is terminally ill, this is something that can be incredibly profound and really therapeutic. That sense of sacredness. It's like that Rumi poem that, he said, there's some kiss that we want with our whole lives, a touch of spirit on the body. And you see that in people who have existential distress. They're aching for something, they're starving for something, they don't know what, they can't name it. So then, psilocybin may not, maybe those results aren't so, too good to be true. Maybe it's just an ingenious fit of medicine and ailment, potentially. So I was floored by these results. I could not wait to get this into our system for our patients and their families. And I thought, right, whenever someone brings this to Australia, I'm sending all my patients. And I was absolutely sure it would take off. And so this is what happened. I have no words for this. I couldn't believe it. It was, it just sort of went through to the keeper. So nothing was really happening. So then, how did it come together? I'm sure you're wondering. December 2017, Entheogenesis Australis put on a fantastic symposium in Eildon. I don't know if anyone went there, but it was stellar. It was really, really good. So I went along to EGA. I heard incredible speakers, our local speakers, who were just the calibre of which blew me away. But then I heard Martin Williams, who's up there, smiley. I did ask for this permission. I said, can I use one of your photos? So this one, he said, all right. So I heard Martin, who is the president of PRISM, speak, and he did a presentation before Rick Doblin. It was titled something like an overview of current psychedelic research in Australia. And his first slide, well, that was his first slide, and the very next slide was, thank you for your attention. So, and of course there was this eruption of laughter, because we all knew it was just utterly ridiculous given the therapeutic potential of psychedelic-assisted psychotherapies, that nothing was happening. It was just crazy to us. But at the same time, it was profoundly disappointing. So that was a big weekend, actually, because listening to people like Rick and Ben Sessa, and obviously speaking with heaps of our local people as well, I had this gnawing feeling in my gut that prompted me to speak with my heads of department, and this is where I was expecting a lot of pushback. And I did speak with them, and honestly, it did not take much convincing once they saw the evidence. So I spoke with my head of palliative medicine, head of psycho-oncology, who is also now one of my co-investigators and co-principal therapist. And so then we approached Martin, and so I emailed Martin Williams, and within 24 hours we were having coffee, hatching a plan. So that was great. We were able to then secure some funding from Tanya de Jong and Peter Hunt, who were heading Mind Medicines Australia. That hadn't been developed at that stage, but they'd given us some funding in Vajradhara in Sydney as well, very, very kindly met that as well. And so then all of a sudden it started to look like it was going to be possible. And then Michael Pollan dropped his book, which was fantastic, and that certainly helped our cause too. So, but then as I was doing this, it was interesting because I've worked on clinical trials before and I knew what had to be done, but this felt very different. I'm looking at this incredible ancient medicine, and I'm trying to create a modern clinical research protocol around it. And unfortunately, there's something that we do that's really annoying in science in the West, and that is that we take things out of their natural environment and we try and boil them down and extract the things and discard the rest. And unfortunately, it means we've lost a hell of a lot of the richness of ritual, for example, and not understanding the symbolism and psychological importance of those contexts in which they were actually happening. Because it wasn't just the mushroom, it was how it was used as well. The indigenous uses of the medicine and how it was shrouded in ritual and symbolic meaning. So this was really, really important for me to think about that. And we knew, obviously, the number of civilizations, ancient civilizations that had been using mushrooms from all over, the world to assist, life transition and promote healing. And that was really key for me because we were assisting a very important transition, and that was one of people accepting death. So I looked to the indigenous ways of doing ceremony and ritual and having a think about that and how we could stitch it into our protocol a little bit more. I'm not the only one who's done this. I think that the people who've gone before me, so the Griffiths and the Ross and Charlie Grob and so forth, have really tried to look at the set and setting protocol and really look at the importance of setting intention, having people bring in things of significance and symbolism for them personally. So that was very important to us as we set out to do this. So yeah, we knew that looking at all the tribes and cultures, regardless of where it was, all over the world, the way that the indigenous and the shaman used the mushrooms was scaffold with ritual and intention. So I was sort of writing this protocol and balancing two opposing worlds, the FDA and ethics govern research and so forth, and then the ancient wisdom and practices of our indigenous elders, and how that really augmented the meaning and efficacy of their experience and how they use it. So with all that in mind, I wrote the protocol, and with the very generous assistance of Martin Williams and my team. So after about 8 months, we were ready to submit, and we tried to make it as hard for them to say no as we possibly could. So 2 weeks later, the 5th of September, I got a phone call from the research governance to tell me that the trial had been granted conditional approval. And I drank so much champagne that night, I will not forget that hangover. All right, sorry, I'm getting on a little bit now, so we'll get to the trial. So this is what we're hoping to do. So we're hoping to recruit 40 patients who are involved in palliative care, or they may be sort of at the cusp of going into palliative care. And I guess I want to say as well, when people hear the word palliative care, they think it's the end. Like, oh, you've got a few weeks, you've got a couple of months. No, that's not the case. And actually now we're getting better at symptom management. We're getting better at keeping people comfortable for a lot longer. And that's actually improving their prognosis and their longevity. So people can be in palliative care for many months and years. Now, that's a good thing for some people, but for some people who are actually really, quite anguished, that's a long time to be sitting with that anguish with no good treatment kind of prospects for their psychological distress. But yeah, so just to give you a bit of an idea that it's not just people who are, in their deathbed, and there are people who are actually quite ambulant and they've got, 2 years prognosis, etc. So this is what we're hoping to do. We've got 40 patients that we're hoping to recruit. We have a 2-phase trial. The first part of this, and you would know, some of you, for those of you who don't, when you try and get evidence for a new treatment or an intervention, what you have to do is you have to subject it to a randomised control experimental design. So then you can say that this is not happening because of a result of placebo or, it's all in the mind kind of thing, that it is actually, statistically happening because of the effects of this intervention. So the first part of this, the first dose, people will either receive, and we're blind to this, it's double blind, the therapists don't know, the participants don't know. They'll either get 25 milligrams of synthetic psilocybin, or they'll get 100 grams of niacin. Now, that's supposed to be our placebo. It's very hard to blind a psychedelic experience. So niacin is what we call an active placebo because it gives you a bit of a flushing effect. You get quite a bit warm and kind of like, ooh, if no one's had a psychedelic before, they don't know. So so that's the way that we blind it. It's as best as we can do. We've searched the world over. It's about as good as we can go. Now that's the first arm. Now that would have been enough for the FDA. It was not enough for us, and particularly for me. Ethically, I could not allow participants who were in desperate need of treatment and seeking this out to not have an experience of the active psilocybin. So the second arm, which is basically about 6-7 weeks later, it's called an open label extension, which basically means everyone gets the psilocybin. So even if you got it the first time, and we're not supposed to know, but if you got it the first time, you then get a second dose. If you want. People can say no. But let's see, they might say yes. I think they might. So yeah, we're using 25 milligrams of synthetic psilocybin. I know that it's funny, when this all came out, we were expecting enormous pushback from the academic and medical communities, with, this is deeply objectionable and all that. And I think they were fine with it. And the biggest concern that we got was from the psychedelic community basically saying, why aren't you using the real thing? And, look, it comes down to 2 things. I can hear people wondering, so I'm just going to tell you. It comes down to quality and dose control, really, because there's such a variation in potency. And then, so in terms of any kind of research that you use, a pharmaceutical grade agent is required. It needs to be pure, it needs to be, all that kind of thing, clean. And it needs to be what they call CGMP, which is commercial grade, good medical practice. So we're not the first ones. It's not just us. It's funny, I had a reporter say to me, do you just give them the mushrooms on a plate? I'm like, no. Well, what does it look like? Much like a Panadol. That's really, oh, okay, so it was quite anticlimactic. So we give them 2 doses, as I say, it's about 7 weeks apart, but we do that first dose very quickly from baseline. We follow them up. We give them sessions. I'll get to the psychotherapy in a moment, but we do a fair degree of preparation. We spend quite a bit of time with them. And then we follow them up for 26 weeks post their second dose. Okay, so we can get sort of measures of how they're faring. We're looking, obviously, our key kind of outcomes are rates of depression and rates of anxiety. So we're looking at that using assessments, so like little checklists, pretty quick ones, little 5-minute numbers. But then we're also doing qualitative interviews with them, because actually that's where the richness is in their personal experience, and it will be very varied and deeply personal. So we want to capture that a little bit more. They're going to have stories to tell us, and we want to hear them, so we need to give them. You can't capture that in a checklist. But that's the stuff, unfortunately, that, when you do crunch big numbers in randomised controlled trials, that's what they want. The other thing is as well, we're doing something pretty novel. We're actually extending on previous research, and that is that we're looking at non-malignant disease. So previously, they'd all looked at cancer, but now we're inviting people in who've got terminal disease, who have end-stage lung disease, or end-stage kidney disease, end-stage renal disease. Renal is kidney. Sorry, I've been awake since 4 o'clock. So, catching my flight from Melbourne. So that's what we're sort of hoping to do, and just talk a little bit about the psychotherapy aspect of it. Because it's not just the psilocybin. This is really, really important to understand. The way that we leverage more of that lasting change in mood and cognition and behaviour is that we're really hoping to, work quite intensively with the integration. That's I think I've called it the secret sauce before. The psychotherapy. This is how it's set up. We have 2 psychotherapists present. The dyad can be male or female. It can be two females or 2 males. Now, again, that's something else that's a little bit groundbreaking, because in previous studies they have basically given a male and a female, and that's sort of rooted in psychoanalytic thinking of, the historical mother-father figure in the room. But we kind of went, well, actually, what happens if you grew up with 2 dads or 2 mums? Or actually, what if you've had trauma and you just feel more comfortable with, your identified sex that you would like to have in the room? So people actually get an option to tell us who they want in that room, in that regard. So there's 3 key phases, obviously. There's the preparation, which we spend quite a bit of time on, and that is where we're talking a lot more about, so things like, doing psychoeducation about psilocybin and experiences that may arise for them. Being careful not to implant sort of ideas in that way, but, this could happen, that could happen. But also then talking about anxiety management. If they were to face a challenging scenario, how to face that, how to get through it, grounding techniques, things like that, mindfulness. And then also doing a fair bit of meaning-centred psychotherapy, which comes into more of the integration as well. Then there's the dose day. Now, that dose day needs to be said that it's actually very hands-off. We're there really as a benevolent, supportive presence. Well, obviously, we're there to monitor their safety and all that kind of thing, but we're really only there and get involved if they signal to us that they need us, or if they'd like to do some talking, or if they've hit a bit of a rough trot, and we can help them move through sort of a challenging experience. But again, it's a personal experience, and we want them to have that personal experience. We don't want to get in the way and go, "Hey, going in there? What's happening?" That would annoy me. No, so yes, of course it would annoy them. And then obviously, just spoke briefly about the integration, but also the therapy environment. We know that people who take psilocybin are exquisitely sensitive to their environment. So while it's on the premises of a hospital, we're in a really lovely room. It's called a retreat, which is nice, where there's a very comfortable, or there will be a very comfortable bed. We haven't got that from procurement yet, but we'll get that. Eye shades, plants, lamps, music. We're also going to provide writing and art supplies for people. so that they can kind of, if they want to, I guess, talk about their experience in a different way, non-verbally. And also, I think worthwhile talking about, so in the integration sessions I forgot to mention as well, we talk a lot about intention, so what they're hoping to achieve from this, particularly with regards to the narrative of their illness as well, and how they see, how they experience anxiety, how they experience depression. So that's a little bit about how we treat that. Okay, now it would be remiss of me not to talk about the risks, okay? This is not for everyone, okay? I don't think I need to tell people in a room who have come to an Australian Psychedelic Society event that you would know the seriousness and the profundity of a psychedelic experience. It's no joke, it's not going in too lightly, so this is, we know that there are risks, largely psychological. So physiologically, actually, it's actually reasonably safe. There's things that obviously we have to look out for, but for the most part, the biggest risks that we need to be mindful of is psychological. So if people have got a history of psychosis or a history of bipolar, we know that that can trigger episodes. It can trigger a first episode, it can trigger a relapse. Even if you have a family history of a first-degree relative, so, being a sibling or a parent, we're just very mindful of that. Now, some people go, oh, that's going a bit far. In saying that, though, we have to be really careful here. So from that point of view, we're being actually quite conservative. But we know, and particularly for, young people who are sort of between the ages of about 14 and 25, the risk of developing, if you have a propensity, if you've got a predisposition to developing psychosis or bipolar, it's going to, well, not so much bipolar, but psychosis is more likely to happen in those at that age group. So that would make me very nervous as well. But so yeah, we know the risks. We know that psilocybin is not safe for people currently. When I say currently, because we don't have enough research on it, maybe something will come up kind of down the track. But for people who've got a predisposition to these conditions, we will not accept them into the trial. Just a couple of other precautions. SSRI or SNRI antidepressants. And the reason that if people are on those antidepressants and they want to be in the trial, we say to them, if you really want to be on it, we need to wean and cease, or we need to cross-titrate you to a different antidepressant before you start. The reason for that is because it's one of safety. Because if you have a bit of a loading of serotonin, it can potentiate what we call serotonergic syndrome. But also, actually, it's more of a bigger scientific risk, actually. So, because serotonergic syndrome is actually quite rare. But if you have SSRI or SNRI in your system, and they're both, you've got that, and then you've got psilocybin, they're both competing for the same receptor real estate, if you like. So then you can get a very varied response. So I might have someone in there, they've got SSRI, or they're taking SSRI, we dose them, and they're twiddling, they go, is that it, really? So they may not get an effect at all, or they could get an effect. So, and it really depends on things like metabolism and, when they take it, how big a dose, all that kind of thing. So that's why we have to have that sort of screen out. Obviously, monoamine oxidase inhibitors, we can't have that. And then we check out things like liver function, cardiac function, kidney function. Unfortunately, we cannot treat people who have got very significant brain metastases or other central nervous system disease, because if we're opening someone up in a very vulnerable way, they may not be able to sort of zip themselves back up. So we need to be really careful of that as well. So we're aiming to kick this off in September. We've had some delays, which are seemingly inevitable in clinical trials, but we are ready to roll. But I guess this is where I'm kind of imploring anyone who happens to be sitting in the audience in the same way that I was that EGA day. And if you are thinking of doing this kind of research and you are in a position to do this, think about this is a great time to be getting involved, and you've got incredible organisations like the Australian Psychedelic Society, PRISM, Mind Medicines Australia now ready to support you. If you want to chat to me, more than happy, send me an email. Don't send me an email, actually I'm getting flogged at the minute, but just, I'll get back to you at some point. And if you have email, I'm really sorry, I will get to you. It's just been a bit of a tricky time, very busy time. But yeah, there's a lot of people here in this community that are happy to help you, and there is such profundity in these compounds and the shrouding of the therapy around that, it's a really good time to be sort of doing this. I think the beauty is once a precedent is set, it is easy to get other research going in the space. So if you're in a position to do something, please get amongst it. And I've just got to send out some love. All right, huge love to Prism, our biggest supporters, collaborators and funders of this, and they were able to secure funding from Vajradhara and from Mind Medicines Australia, without which it would be very difficult to do this. Clinical trials are expensive. It's a lot of hands on deck. It's a lot of clinical time. So huge thanks to them. And a huge, huge love to USONA Institute, who are providing our psilocybin for free. Yeah, I love them too. No, they're amazing, and they've been incredible in terms of their support of our protocol and developing our research design as well. So there are organisations, there are people out there to help you. The last big love, all these humans out here. So this guy, Martin Williams, Ben, who's been very, very influential as well. This guy here, Chuck Razan, who's the lead scientist at USONA, who's been invaluable. This guy here, Charlie Grob, he was the first one to do open label study of psilocybin in cancer patients. It was 2011, Archives of General Psychiatry. I am very proud to say he's one of our international collaborators. Is Bill Richards, who is just gorgeous. He's very sweet. Roland Griffiths, who is just ridiculously busy, but he always sends me a little email to see how things are going, which is gorgeous. And Prash is a bit of a face on the scene, and he's also very inspirational. These ladies here, I put in here. Alicia Danforth was one of the first ones. She's in the US. She was one of the first therapists in the NYU trials. UCLA trials with Charlie Grob. I don't know her personally, but these are my mentors. There's not a lot of females in this space. So it's nice to have that. And then there's Rosalind Watts from Imperial College as well. These guys are my incredible team, whom are some of the most talented psychotherapists I've ever met. They're gorgeous. They're doing a lot of work in their own time because we believe in this. We want to see it get off the ground, and we are just, so proud to be doing this work. And please know it's in good hands. We are treating it with the utmost respect, and thank you very much for your attention.